All right, so we're going to talk about improving quality measures, and this particular session is related to the percentage of long and short stay residents who are self-reporting moderate to severe pain. So the quality measures related to pain, you have the long stay that are greater than or equal to 101 cumulative days in the facility, and it's the residents who self-report moderate to severe pain. And then your short stay is also measured for this, and those are the folks that are less than 100 days cumulative in the facility, and they too, residents who self-report moderate to severe pain. What's this mean? It means that every single resident's pain level is assessed, no matter whether they've been there under 100 days or greater than 100 days, and it's our job to meet their needs for pain control. So when we look at BO700, that's where CMS basically determines whether or not they believe somebody is interviewable. So if you're saying in this section that someone is rarely or never understood, you're able to skip through the interviews and go directly to staff assessment without much trouble. We want to ensure that people are still using cue cards for all of the interviews, for the BIMs, for the memory stuff, for the pain activities, so that staff and residents, that you don't get comfortable with just skipping over through certain ones. They're meant to be very standardized questions with very standardized answers, and you want the resident to be able to refer back to that cue card and either be able to point to their response or use a number instead of trying to remember. If any of you have ever called up someplace and you get one of those press 0 for this, press 1 for that, press 3 for this, press 4 if you want to hear this again. If you're like me, I'm writing down, well, I think I need number 2, but let me listen because they said that all of their options have changed, and then I'm writing down a 3, and by the time I get there, it's like I better listen to it all over again. That's what an interview is like for somebody who has cognitive impairment. You're asking them to remember all of those, so they're either going to remember the first or they're going to remember the very last one. And in either situation, you're not giving them full benefit of the doubt to answer that appropriately. So you really should look to see that you're using those cue cards for pain and that your social service department's using it for their sections and activities as well. So long and short stay residents, the MDS sections that are going to trigger the quality measures are in section J. So JO200 is asking right off the bat, should the pain assessment interview be conducted? And it will tell you that if you're saying that the resident is rarely or never understood, you can skip and complete it and go to pain indicators, and you can go to staff assessment. If they say yes, you're going to continue. If you're going to do the interview, you're going to go through all of these things asking about the pain. So you're going to ask them about pain, and the answers are going to be no, yes, or they were unable to answer. JO400 talks about pain frequency, and so you're going to ask the resident, how much of the time have you experienced pain or hurting over the last 5 days? When they start answering almost constantly and frequently, that's when we have to start being concerned about that. When they're at rarely or they don't answer it or it's occasional, it's not too much of a problem unless they have an episode in the 5 days that they say was severe or horrible. So your long stay, short stay residents, again, pain intensity at JO600. They want you to either give a numeric scale or a verbal descriptor, all right? And if you're going to say, if the resident's going to say they have moderate, severe, or very severe and horrible pain, that's when you're going to start to have these triggers. The percentage of long stay residents who report constant or frequent, moderate, severe pain in the last 5 days or any severe or horrible. So even if they say rarely or occasionally, but then when they get to the intensity, they answer severe or horrible, you will still trigger. So the folks that are going to be included in the numerator are, again, moderate, severe pain reported. Okay, it's only going to trigger your quality measures when it's from an interview response. Your staff assessment responses are not going to trigger this. So the triggers for numerator, moderate, severe pain that's also reported as constant or frequent. Okay, so if they have moderate to severe and it's only rarely or occasionally, you're not going to have a problem with that unless they report the severe or horrible at any frequency. Okay, so know what all that is. People that are going to be excluded are admission assessments, PPS, 5-day assessments. If you don't complete the interview, those people are not in there. And the interview is complete, but no frequency or intensity is coded. So there's dashes in there. This is risk adjusted for people who have BIM scores of 13 to 15. Do you know what the 3 levels of BIM scores represent? You have 0 to 7, that's severe cognitive impairment. You have 8 to 12, that's moderately cognitively impaired. And then you have 13 to 15 that are considered cognitively intact. So they're going to risk adjust this classification for you when people are alert and oriented, because they're making the assumption that those people report their pain appropriately. They can get up and move around if they're in pain. They're not going to be waiting for pain medications, or it being unrecognized because they have other diagnosis. So it does get risk adjusted by that. Because they're thinking that they're independent and or moderately independent in their decision making on the prior MDS. MDS sections J0200, should pain interview be conducted, and J0600, we talked about this, the pain intensity. What target dates are used? All assessments in the most recent 3 months. All assessments means that even if you get it wrong and you modify the assessment afterwards, it's still going to take the wrong information and calculate it into your quality measures. That's why it's imperative for you to get it right before you send it. You need to be looking at this information before it gets transmitted, because once it does, you still are going to be obligated to fix it if it's not right, but it's not going to change your quality measure information. Management, using cue cards for the most appropriate level and frequency to be coded. Short stay, the description is the percentage of short stay residents with 1 episode of moderate or severe pain or horrible pain at any frequency in the last 5 days. So the short-term people, it's a little bit easier for this to be triggering for them. Daily pain with 1 episode that's moderate to severe, coded as constant or frequent, or the horrible excruciating at any frequency. So just once they say that in the past 5 days that they've had horrible and excruciating, it doesn't matter how often you say they have pain. They're not going to be included in the numerator if the interview is not conducted, if the presence of pain is not answered, and the frequency is not answered. So if you have dashes in there. Target dates, again, all assessments, but this is for 6 months instead of 3 months. Consideration, all means all data. So even if you modify the assessment, you're not going to change that, and using your cue cards. As with every quality measure, we're reminding you not to submit your managed care assessments that are being used for payment only. The 14s, the 30s, the 60s, any COTS, any of those types of things, do not transmit them for managed care. Your 5-day would actually be an admission that's taking the place of a 5-day, because if it needs to be submitted. So how can we improve this? We need to take a look at our pain medication orders and the way we're writing them. Are they routine medications, or are we only giving people PRN? If you're having to wait for the person to get to a level of pain that they want to ask for the medication, then they're asking for the medication, then they're waiting for the medication to come, then they're waiting for the medication to work. You can bet that they're experiencing pain, and it may be the time for an interview, and you're going to be asking the questions of somebody who's kind of ticked off and been sitting in pain for hours waiting for this whole process to get where they are, and that's the only thing they remember. If they're only on PRNs, try getting routine orders and then something PRN for the breakthrough. A lot of doctors, because of all of the controversies with narcotics and everything going on in society, they're really sketchy about doing that. But when people have pain, they need to have that pain treated. When were the last changes made to the pain regimen? So yeah, maybe they do have routine meds, particularly your long-term care people, but they haven't been changed in a year and a half. So now they've established a tolerance to that, and it's not working for them. How often are they having to take this breakthrough pain medication? Are we medicating them prior to therapy or wound care? Have we done a comprehensive pain assessment? Are we treating the right type of pain? If they have neuropathic pain, then the narcotic is probably not going to help them. Are they showing signs and symptoms of depression because of the pain? Maybe they're not as friendly as they are when you're doing your interviews. They don't want to visit with you. Has their ADL function declined? Are they staying in bed more, not leaving the room for activities or meals? Even though they haven't reported pain, these can be all indicators that pain is being experienced. Is there a trend with one type of resident? So not just whether they're long or short stay, think about their diagnosis. Are you getting a lot of ortho patients over a weekend and having trouble getting pain medications timely? Look at those processes. Look at your pharmacy responses. Have you had turnover in staff who don't know the residents and can't recognize that they may be experiencing pain and just not saying something? and then use the pain CAW at your weekly risk meetings. So if you're having somebody who's experiencing these moderate to severe or horrible pain, and it's constant or frequent, you want to talk about those people each week at your risk meetings, and you should have their CAW available so that you can look at all the different things that might trigger you to look at something that might be causing it that you wouldn't have otherwise thought of. A lot of times for pain, all we're doing is looking at, going to see if they can get a new medication when there's lots of other things that might be going on, and the CAW can help you use something outside of your standard toolbox. And when we're thinking about pain control, like I say, there's many different factors. So we have to remember to look at the big picture for the patient.